Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. Virtual meeting held on 13 December 2022. More than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good evening, one and all. I welcome you all to today's Navigate Medico CME program. I would now like to invite Professor Umesh Kapil sir, the Secretary of National Academy of Medical Sciences, to provide his welcome address.
Namaskar and good evening to all the participants, all the speakers, and particularly Dr. Awadh Kishore Pandit sir, who has very kindly agreed to deliver a lecture on stroke, what you need to know for the postgraduate students. The Navigate program, which has been initiated by National Academy of Medical Sciences, is essentially for the postgraduates all over the country. And what we understand that there are about 100,000, about 1 lakh students pass out MBBS, and out of which only about 6,000 to 8,000 go into the formal MD/MS courses, and say about similar number undertake the DNB courses. Remaining, we have about 80,000 MBBS students who want to pursue their post-graduations, and they do not have facilities to update their knowledge so that they can pass the postgraduate NEET examination. So in view of that, National Academy of Medical Sciences made an humble beginning by inviting most eminent faculty members from All India Institute of Medical Sciences, from National Institute of National Importance, and other eminent people to join and deliver the lectures. Now, keeping that thing in mind, we have today's lecture by Dr. Pandit, and we hope that these lectures will be utilized by all the postgraduates. Plus, what we have done is we have developed a virtual NAMS library in which all the lectures which are being delivered over here, along with their PowerPoint presentations, are being uploaded so that all time to come, the eminent speakers' lectures, videos, and PowerPoint is available to the postgraduates. Now, this is a humble effort of National Academy of Medical Sciences, and we are sure that we are going to succeed gradually. It will take time, but yes, what we are finding that the thematic lectures are being attended by a large number of postgraduate students. They keep on visiting the NAMS website and keep on listening to the videos which have been uploaded over there. Once again, my sincere thanks to Dr. Padma ma'am, who has been agreed to be the chief coordinator for a series of lectures on common neurological issues. And in that, we already have 3 lectures. We hope that today's lecture would be another successful lecture. With these few words, my welcome and thanks again. Thank you very much.
Thank you, sir. It's a honor and a privilege for me to introduce the speaker for today's session, Dr. Awad Kishore Pandit, sir, who is an associate professor in the Department of Neurology at AIIMS, New Delhi. Sir has completed his MD in General Medicine and DM in Neurology. Sir is also a fellow in DBT INCRE and also has got a fellowship in neuroendovascular therapy in Japan. Sir has got the DM. Sir has done his DM Neurology in AIIMS New Delhi and MD Medicine from Mahatma Gandhi Institute of Medical Sciences and MBBS also from Mahatma Gandhi Institute of Medical Sciences. Sir has around 82 original publications and 3 book chapters. He is also recipient of the ML Soni Award and the Best Postgraduate Student for DM Neurology in 2014. Sir has multiple ongoing projects to his credit, including the project on wearable electronics in swallowgraphy for stroke patients, cost-effective analysis of evidence-based interventions underlying acute ischemic stroke, a retrospective study of patients in a tertiary care hospital, Delhi, India, efficacy and safety of injection 10-hectare place in 4.5 to 24 hours imaging eligible window patients with acute ischemic stroke, fever, hyperglycemia, swallowing, and hypertension, management in acute stroke, a cluster randomized trial, an intracranial mucormycosis in COVID-19 patients, a case control study, an exploratory study to identify candidate CSF biomarkers in idiopathic intracranial hypertension without listen loss. Without further delay, I would like to invite Dr. Awad Kishore Pandit sir to start this session.
Thank you, Dr. Preeti, and thank you, NAMS. And definitely it is going to be a good input for the postgraduate students. And I must thank our Chief, Professor Padma, and NAMS, who opted me to give this lecture. And I have been given a topic. Just confirm me if this screen is visible or not.
So your Zoom screen is visible. Yeah, now it's visible. Sir.
Now it's visible.
Yes.
So I will be speaking on stroke, what you need to know. And I must say that I will limit this to ischemic stroke because it's a vast topic, and I must say that postgraduates to concentrate because I will be elaborating few facts and the practice parameters which are practically expected in the care of acute stroke patients. So this is stroke. You see a person in community or any place, they have facial drop, they have arm weakness, they have difficulty in speaking. So you must suspect stroke. So going to the various plans by globally, so we are expecting that it should be identified. Stroke identification is important so that we can go into a further step in its management, which includes pre-hospital and an emergency department management, acute care, prevention, rehab, and reintegration and recovery following stroke treatment. So there are various guidelines, there are evidence, but what best practice we should do is what we are going to discuss. So if we have a patient in emergency, so this is a minimum expected checklist which should be done. We should have a quick triage, see that the patient airway, breathing, circulation, and disability has been quickly evaluated and specifically managed. If you have a suspicion of acute stroke, we should do a quick clinical history and examination. And I'm insisting that we must know the window period and NIHS score, which I'll be telling you if it's a suspicious case of acute stroke. Minimum and at least and only one thing which is expected in emergency, if a suspected stroke is there, you should have a random blood glucose. And at the same time, you can do a blood sampling. Put 2 IV cannulas in both the arms and post the patient for neuroimaging, CT or MRI as appropriate case-wise as you think, and ischemic or intracerebral hemorrhage, accordingly then specific management has to be considered. So I'll be going in detail of each of these components and preferably which are more important. So I talked about the scale in the emergency department, that is NIHS score. And this score has total, it points from 0 to 42, which includes level of consciousness, orientation, commands, gaze, visual fields, facial movement, arm, leg weakness, ataxia, sensory, language, articulation, and extinction or inattention. So we get a score from 0 to 42. So this NIHS score is very important because it is uniform across globally, and it quantifies degree of neurological deficit. It facilitates communication and helps us in various management and complication identification. And there is a follow-up scoring, which is named by modified ranking score, which is MRS, which extends from 0 to 6. 0 is nothing, no symptoms, and 6 is death, and 1 to 5 spans from the degree of severity of the patient. So in emergency, the first step after clinical evaluation is we go for head and neck imaging. So this is must before initiating any form of specific therapy, and it should be done as quick as possible. So patient undergoes first non-contrast CT, then MR or CT angio, CT pulmonary or MR angio, case to case basis. So minimum first expected is non-contrast CT head and CT angiography with CT perfusion. So this imaging has basic purposes. First, to rule out intracerebral, to exclude intracerebral hemorrhage, because the ischemic stroke will have a different pathway of management. Imaging will most likely possibly may rule out any stroke mimics. CT angio or CT perfusion to see if the patient has a large vessel occlusion. In that case, patient would need a mechanical thrombectomy as a standard of care. Then MR diffusion flare mismatch is done for patients who have come with wake-up stroke or for whom we do not know when were they seen last normal. So in that case, we can have a tissue window and we can plan a thrombolytic therapy for that patient. So that is why the neuroimaging is important. So few examples, patient comes with a right hemiparesis, we did a CT and there is a hypodensity in the left insular cortex and there is left MCA M1 occlusion. So we are sure patient has clinical suspicion of stroke, there is a hypodensity and there is vessel occlusion. So we are clear there is an acute ischemic stroke with large vessel occlusion. In CT, we also expect to know the aspect score. So aspect score is basically, it spans from 0 to 10. If you see, this is a scan. The first scan is at ganglionic level. That is at basal ganglia level, and this is just above that, supraganglionic level. So we take 1 or 2 segments above, below ganglionic and supraganglionic, 1 or 2 frames above and below. And we mark them as M1, M2, M3, that is the MCA territory, and supraganglionic M4, M5, M6. So 6 scores. 1 score is for caudate, lentiform, internal capsule, and insular cortex. So these are the 10 areas which has to be marked, and we deduct 1 with every area of involvement. So if it is 10, it will go down to 9 if 1 is involved, or if 5 is involved, it will come to 5. If almost 9 areas are involved, it will be 1. If all the areas involved, the aspect will be 0. So this helps us in objective determination of the size. The CT imaging also helps us in knowing the collateral circulation, and this collateral circulation is depending. For example, this is the site of occlusion. So we want to see whether there is any collateral flow from other areas. So that is the condition in which we want to know collateral circulation. So immediate, there will be collaterals which are mainly hemodynamic, and lately the collaterals may develop because of the metabolic changes. So I will just give a brief that these collaterals are basically influenced by patient's age, metabolic syndrome, hyperuricemia, mean arterial blood pressure, and cerebral blood perfusion. So we have many factors which we can manage so that we maintain the collateral circulation. And this is important factor in outcome of the patient. So I will not go very much detail, but there are intracranial collaterals and extracranial collaterals. So intracranial collaterals are mainly which connects the vessels of circle of Willis, and there can be connections between them like ICA to PCOM artery, anterocerebral artery to ACOM artery, and there can be branches of MCA, ACA, and PCA which anastomose with the terminal branches within this territory only. MCA branches will join to ACA, MCA will join to PCA. There can be tectal plexus collaterals in which posterior cerebral artery will have collaterals joining with the vessels on the tectal rami. And there can be leptomeningeal collaterals in which the major vessels can contribute to connect the arteries from the leptomeninges to the vessels in the intracranial circulation. And there are collaterals in the extracranial part also. And these collaterals have been assessed in acute stroke management with various modalities. So like most common and recommended modality is multiphasic CT angio, in which this gives us a 3D imaging of the various arteries which are covered in this collateral imaging. For example, if there is a vessel occlusion in left M1 MCA, if we see there are good number of vessels which are visible in this area. So these are, when I showed you multiphasic CT, so there are 3 phases in which it collects the information. And in first phase is this is early arterial phase, late arterial phase, and this is almost early venous phase. So we have good collaterals here. And if we see, there are intermediate collaterals within this area and lesser than this. And these are poor collaterals. If you see on the right, M1 MC is occluded and there are hardly other vessels which are visible. So we do a collateral scoring on this CT angio, and if you see, if there is less than 50% of arterial territory is showing vessels, for example, this is the area in which we hardly see any vasculature. And this is collateral score 2 if we see anything about 50 to 90%. And if it is comparably similar to the opposite normal area, then we say it is almost 100% collaterals are there. So imaging, this is another parameter which has to be calculated. Perfusion imaging is also done in acute setting because nowadays there is a concept called tissue window. So other than a clinical window period, we also want to see a tissue window because we want to salvage the ischemic penumbra. So that should not be missed. And that is why perfusion imaging is important parameter in initial evaluation of imaging. So this part conceptually, we know that in gray matter, the blood flow is 60 ml per 100 gram per minute. White matter, it is 25. Cerebral blood volume is gray matter is 4 ml per 100 gram. White is 2. And mean transit time in gray matter is 4 seconds, and in white matter it is 4.8 seconds. So what we meant core is this infarcted area, and then there is hypoperfused area is oligopenumbra, which is mostly considered a reversible zone. So that is why the concept of core and penumbra has come up as tissue window in which we can salvage this part. So I was telling about mean transit time. So when we inject a contrast in the the affected vessel, so the contrast will take some time to drain out through that veins or in the infarcted area. So the maximum time it takes to take up in that area before it drains out, we call it as time to peak. And complete drainage of that contrast, the time taken, we call it as mean transit time. So that is why I told you, if we get these values of time to peak, mean transit time, so we come to know that what is the part we are dealing with. So if we get these values, we are easily able to depict the core and penumbra, and accordingly we can calculate the mismatch. I will show you the examples later on. in the case scenario. So core is the area where we have a cerebral blood volume and cerebral blood flow. They are severely affected. So to say core, we say the cerebral blood volume is less than 2 ml per 100 gram. And this Tmax, it is more than 6 seconds. So more than 6 second Tmax will happen in the complete zone of core plus penumbra. So if we get to know the complete Tmax and if we come to know the cerebral blood volume, then we can calculate the penumbra volume also. So this is an important tissue window biomarker, which is currently important in acute stroke management of cases. So we have told the emergency checklist, then we have done the clinical evaluation. We must know window period, we must know the NIHS scoring, then we have discussed the basic immediate neuroimaging which is required. If it is a ischemic stroke, as I showed you examples, so first and foremost priority is we go for thrombolytic therapy. So you must be aware of various things of thrombolytic therapy. So this was the first drug which was approved in thrombolytic therapy in 1996 after the famous NINDS trial. So this has basically been added on with various major criteria. So the new addition is cerebral microbleeds. So I have kept this as an introductory part in thrombolysis, that please do not delay your treatment searching for cerebral microbleeds, because there is a recommendation that we must know the cerebral microbleeds. If there is more than 10 cerebral microbleeds, which can happen which have been found in 30 to 47% of patients who have received altiplase, and it has increased risk of bleeds to the extent of 30 to 47% in comparison to no cerebral microbleeds, 1% to 4.4%. So do not withhold the treatment on presence of CMBs, because we do not have a substantial information based on randomized controlled trials, because these are all subgroup findings of trials which have enrolled hardly 50 or 100 patients. And this altiplase benefit is all time dependent, so do it as early as possible, and is also valid thrombolytic therapy if there is diffusion flare mismatch, suggesting that the window period is less than 4.5 hours. So what do we do for thrombolytic therapy? So what is the practice? We make sure there is clinical diagnosis of acute stroke. We have a checklist for indication of IV thrombolysis by its inclusion and exclusion criteria. We must see that there is persistent and it is measurable deficit. CT or MRI has been done and intracerebral hemorrhage has been ruled out. The blood pressure parameters are met, and we have a large bore IV peripheral lines, and we know the body weight, so that we are able to proceed for thrombolytic therapy. We have to consent from the patient regarding its benefits and risks, and we have to tell that if the patient has reached in 0 to 3 hours, there will be 32 patients who will benefit from this thrombolytic therapy of altiplase, having a good functional outcome, that is modified ranking scale of at least 2 or better, and 3 patients will be harmed. If the patient has come in 3 to 4.5 hours, lesser number of patients will be benefited. Out of 100, 16 will be benefited and 3 will be harmed. So thrombolysis therapy is currently recommended up to 4.5 hours. So altiplase dosage is 0.9 milligram per kg, and 10% of dose is to be given over 1 minute as a bolus dose, and rest of the dose, it should be given slowly in infusion over 60 minutes. And we have to make sure that we hospitalize the patient. We have to observe if the patient develops headache, acute hypertension, nausea, vomiting, or there is worsening of neurological deficit. In this situation, stop the infusion, obtain an emergency CT. Blood pressure has to be managed every 15 minutes during and after IV altiplase infusion for 2 hours, then every 30 minutes for 6 hours, and then hourly for 24 hours. I would say that these are the very important parameters which should be observed, monitored, and they should be treated. Otherwise, it has complications, and mainly most dreaded complication is symptomatic intracerebral hemorrhage that can affect the outcome. Regarding placement of nasogastric tube, catheters, any peripheral lines, they have to be done either immediately before thrombolysis, and it should be avoided in first 24 hours. And after completion of thrombolysis, a repeat imaging should be done at 24 hours before we start the preventive antiplatelets and antithrombotics. This is repeat. So if you have a symptomatic intracranial bleed, what is to be done while the patient is on alteplase infusion? So first step is we stop the alteplase infusion, we request an urgent CVC, INR, the clotting parameters, fibrinogen level, and we request blood bank, and we do a immediate non-contrast CT, and we have to infuse 10 units of cryoprecipitate. And as you get the fibrinogen level, if you find fibrinogen level 150, we have to repeat 10 units of cryoprecipitate, and we can also give additionally tranexamic acid if it is available. And if there is intracerebral hemorrhage, it should be accordingly managed, and that may require surgical interventions. There could be complications like orolingual angioedema, which may require airway protection and steroids if there is a severe respiratory distress. There are other drugs which have been approved other than alteplase. So currently, another drug which is frequently used is tenecteplase. And tenecteplase we choose as a dose, recommended dose in our country is 0.2 milligram per kg body weight. And there is no specific comparison that the alteplase is better. Tenecteplase is, as far as efficacy, which have been tested in various trials. But certainly tenecteplase is better because it is easy to administer. There is nothing called continuous infusion which are required as in alteplase. And biochemically also, tenecteplase has better fibrin sensitivity and has lesser systemic bleeds. So the current situation, tenecteplase is preferred over TPA, that is alteplase. So if we have done with thrombolysis, it is not that it is one by one. Parallelly, if you find that there was large vessel occlusion in the CT angiography, CT perfusion, so we have to make sure that we have parallelly decided whether the patient should undergo mechanical thrombectomy. Mechanical thrombectomy is a invasive process. It's an endovascular procedure in which we try to remove the thrombus which has occluded the vessel and led to stroke. So what makes us also feel that patient may have a large vessel occlusion? So all the patients of stroke should undergo CT angio and perfusion. However, there are studies and meta-analysis in which it is found that if NIHS is 10 or more, there is high likelihood that we are going to find large vessel occlusion. However, in the trials to increase the sensitivity, NIHS score of more than 6 has been kept so that we do not miss the large vessel occlusions who can benefit with mechanical thrombectomy. So what are the various indications of mechanical thrombectomy? So we know quite number of patients we may get large vessel occlusion. So currently the recommendations are, if the patient got thrombolysis or is on flow with thrombolysis, mechanical thrombectomy should be considered, and there is strong evidence and recommendation. So the indications are patients pre-stroke MRS of 0 to 1, and the causative vessels are ICA, internal carotid artery, M1, MCA, age more than 18 years, NIHS more than 6, and aspect score of more than 6. And the treatment should be initiated within 6 hours of symptom onset. These are the typical patients who should not be denied of mechanical thrombectomy. However, with lower evidence, now there has been thrombectomies which have been tried with M2 or M3, the distal occlusions of middle cerebral artery territory. Also 6 to 16 hours and 16 to 24 hours selective cases may undergo thrombectomy, and it is strongly recommended. So these were the various trials. I will not go in detail. I would just want to mark you that these trials, if you see the odds of benefit of thrombectomy is all more than 1.7 and to the extent of 2.9. Even in delayed window trials, it was 2.94. Almost 3 times benefit as compared to no thrombectomy. So according to time, if you have early thrombectomy, the chances of achieving a good functional outcome decided by MRS 0, 1 and 2, it is better in early time period if reperfusion is achieved. Now, this is a paradox that says that the Hermes study I showed you, that if the patients have each hour delay, the chances of good clinical outcome is reduced. However, I showed you Dawn and Diffuse trial, which are delayed window period thrombectomy. They had good clinical outcome. I showed you the odds were better than in the early period. So what is this paradox? So this all brought the concept of collaterals. So this helped in selecting these cases, and it is important in current thrombectomy cases, and which led to this Dawn and Diffuse trials in beyond 6 hours. So imaging in thrombectomy, initial we should do CT angio or MR angio, and I've already said less than 6 hours, no confusion, you do CT angio or MR angio and go for mechanical thrombectomy. More than 6 hours, these two trials, the Dawn and Diffuse criteria, which has to be used. The Diffuse trial has no clinical threshold of NIHs. Only thing it wants is infarct, that is the core which I showed. It should be less than 70 ml, and ischemic tissue, that is penumbra to infarct ratio, should be more than equal to 1.8. I will show you an example. But in Dawn trial, there was an NIHS cutoff more than 10 and 80 years age cutoff. So if 80 years or old, NIH is more than 10, so we need less than 21 infarct core. If less than 80 years, the NIH is more than 10, less than 31 ml infarct, or if NIHS is 20 or more, the infarct volume larger is also acceptable for the patients to undergo mechanical thrombectomy. So for this extended period, that is 6 to 24 hours, we need to have CT perfusion imaging so that we can select these patients for thrombectomy. So as this slide I had already showed you, the cerebral blood volume gives an idea of core MTT, that is the mean transit time. It tells us about both the core as well as penumbra, and mismatch is penumbra, which is the reversible ischemia, and we have to subtract the core part, that is reduced from the cerebral blood volume, so that we can get the mismatch. So for example, if we see this cartoon, if you see, this is the core which we got from cerebral blood volume values, and this is the complete MTT volume. So this will include both the penumbra and the core. So there is a mismatch, we can see. The MTT volume is larger than the cerebral blood volume. So if we subtract MTT volume minus CBV, we will get the penumbra. And penumbra divided by this core, it has to be more than 1.8 to select the patients for thrombectomy. In this picture, we see there is no difference. So there is, the complete tissue is infarcted. So it is all core, there is no penumbra. So these are not selected. So if we see this images, we see there is CT, it is symmetrical. The cerebral blood flow is symmetrical. Cerebral blood volume is symmetrical. MTT area is also symmetrical. So this is a normal perfusion image. If we see this patient presented with left hemiparesis, CT showed early signs of ischemia. There is loss of gray white matter differentiation. The sulci are effaced, and there is early sign of ischemia. Right, and there is hypodensity in the white matter also. So it looks like a larger area of infarct. So if we did a CT perfusion, and if you see the cerebral blood flow is reduced in the whole of the area, and there is a small area of cerebral blood volume, and this complete is MTT. Right. So if we see the cerebral blood flow is reduced, cerebral blood volume is reduced, and there is MTT. Right. So most of the area is cerebral blood volume, and this is complete. So the complete area is as infarcted as compared to this. This is visual. We also get volumes. So this is the area of core, which is by the cerebral blood volume. So we get volume 23 ml, and this is the MTT area, volume 128 ml. So mismatch is the penumbra will be 128 minus 4, 105. If we divide 105 from the penumbra to core, it becomes 5.6. So if this is a 59-year-old male, who had a wake-up stroke of 13 hours when he was last seen normal, and NIHS score was 23, and CT perfusions, which values I have shown you, and this is the infarct, this is the complete MTT area, and the region of perfusion, this MTT area, the Tmax is more than 6 seconds, you can remember, and the mismatch ratio is 5.6. So this patient is candidate for mechanical thrombectomy. So what happened with other sites of involvement? This was for ICA and MCA. For distal M2, M3 occlusions, there is no robust data, but still they have found in various studies good recanalization, good functional outcome. However, we need better future randomized trials to confirm. However, these M2 thrombectomies are in pipeline, and this will come very soon, in which the devices have been evolved, and it will be a standard of care for M2, M3 occlusion also. So these are the supporting evidence for distal occlusions, which are positive towards it. What if it is stroke severity? I said stroke NIH is more than 6 or more should be included for thrombectomy, and also for thrombolysis NIH is more than 5, that is 6 or more should be considered for thrombolysis. So because this happened because all the trials have included patients more than 6 except this trial for thrombectomy, which included NIHs of more than 6, more than 2. So higher NIHs did better, and less than 10 showed no difference. So stroke severity was kept cutoff of 6. However, we do not know what will happen with less than 6. Most of these patients who have large vessel occlusion with mild stroke NIHs less than 6, they are excluded from thrombolysis, thrombectomy. But I would still suggest, if the patients have disabling symptoms like isolated aphasia, distal weakness, that is loss of dexterity, dominant hemisphere involvement, they should be considered for thrombolysis and mechanical thrombectomy. But we always go for evidence. But if we see this was a meta-analysis of retrospective studies with NIHs less than 6. If we see here, there is no significant difference. In fact, there was more intrasymptomatic intracerebral hemorrhages in cases who got thrombectomy for milder strokes as compared to the thrombolysis. So what is the situation of bridging therapy? That is thrombolysis followed by thrombectomy. So nowadays we see there is drip and ship. For less than 6 hours, we can go for this bridging therapy. Nowadays, there is a concept that whether we should combine thrombolysis and thrombectomy, or we should get away with thrombolysis. If there is large vessel occlusion, go for thrombectomy directly. So just if we see this conceptually, if there are fibrin-rich thrombus, it is difficult. It is difficult for thrombectomy because it is compact and it is difficult to retrieve. And if it is RBC-rich clot, then it will get easily entangled in the thrombectomy, but there is distal fragmentation. However, in thrombolysis, if it is fibrin-rich, again it is difficult because it's very compact, small pores. So the thrombolysis is difficult. While this thrombolysis, this is easy for the RBC clots. So there was a question whether we should do a direct thrombectomy or not. So there are only 3 randomized controlled trials, and there are 9 observational studies in which this is the largest randomized trial, and this also showed not much difference to give direct thrombectomy. I will not go in detail, but summarize. If you see, randomized trials did not show any significant difference if we do direct thrombectomy versus bridging therapy. Similarly, observational studies also did not show any good functional outcomes, also mortality, no difference. In both the types of studies, there was no difference in recannulation. However, there was more significant symptomatic ICH in observational studies in cases of direct mechanical thrombectomy. So, in summary, there is no significant difference in 90 days functional outcome as far as direct thrombectomy is concerned. So it is similar, direct thrombectomy versus bridging therapy. In fact, there were more symptomatic hemorrhages and any intracerebral hemorrhage in cases who have undergone bridging therapy, that is combined thrombectomy with thrombolysis. So this concept is still not being recommended for direct thrombectomy. If patient is eligible for thrombolysis, they should get thrombolysis followed by thrombectomy if there is large vessel occlusion. So this was also seen in the recently published Angel Act registry from China, which included 111 hospitals, and they also found that there was no significant difference in the functional outcome as depicted by this analysis, in which the mechanical thrombectomy and combined had equal outcomes. So if we see here, there was more symptomatic intracerebral hemorrhage in combination therapy. There was more embolization in combination therapy, but there was no difference in functional outcomes. So still there are moderate to high quality RCTs and observational studies, and this needs to be further confirmed. So we still recommend thrombolysis followed by thrombectomy, no direct thrombectomy till we get more results. So does the age matter? So there can be significant pre-existing disabilities which can affect the outcomes. So there is no data in which we say that if the patient has previous MRS score of more than 1, who should not undergo standard of care. But if we see the various trials of thrombectomy, they found more than 80 years of age patient, they did much better than the younger patients with odds ratio of 3.68. And similarly, this study also showed a better outcome in age more than 80 years, better functional outcome than younger patient. So age, we should not be a exclusion criteria if there is some condition called tandem lesions, in which you can have tandem lesions, means there are double lesions. So there can be proximal lesion like neck internal carotid artery, and there is distal intracranial artery. So these are present in about 10 to 20% of the cases. However, the distal vasculature thrombectomy or acute thrombolysis is recommended, but acute state intervention like carotid artery stenting is still under debate because there can be hyperperfusion injuries or complications. So in the RECOAST study, it says that conservative approach without stenting in case of adequate primary collateral suppression by circle Phyllis may be reliable and safe till we get a future confirmation. So these were the treatment which was immediately very important in functional outcome, that is thrombolytic therapy, or your ABC, clinical evaluation, your imaging, thrombolysis, mechanical thrombectomy. We are expecting only blood glucose in emergency so that you treat it if it is less than 60, and we recommend range 140 to 80 in cases of acute ischemic stroke. ECG, troponin, chest X-ray, it is required, but it should not delay in treatment in the form of thrombolysis or thrombectomy. Swallowing functions are to be assessed because if there is bulbar dysfunction, decreased level of consciousness, then patient may require airway support and ventilatory assessment. And hyperbaric oxygen is not recommended, except when you are suspecting air embolization. In that case, it is recommended, otherwise it is not recommended. Most important part is blood pressure management in emergency, as I have shown you how we have to monitor. On hospitalization, we have to monitor, then every frequently, which I have told you, for every 15 minutes in first 2 hours, then every 30 minutes in next 6 hours, then every hourly for next 12 hours. If thrombolysis is planned, if thrombolysis is not planned, still we have to monitor and treat it. If thrombolysis is planned, we maintain systolic blood pressure less than 185 and diastolic 110. Even if the patients have undergone or planned for thrombectomy, this target is reasonable because we do not have robust evidence what is the blood pressure which has to be maintained, but this has enough shown to be of reasonably beneficial to maintain less than 185 by 110. Even if you have blood pressures more than 220, 120, so there are specific conditions in which it should be lowered. And if it is more than 220 by 120 and who are not planned for thrombolysis, thrombectomy, then we have to reduce the blood pressure, but it should be 15% in first 24 hours. Not that we have to reduce it very less immediately. It affects the outcome. If it is less than 220, 120, if we are not planning for alteplase or thrombectomy, then we can wait and we can start antihypertensive treatment after 48 to 72 hours. Blood pressure followed by temperature is also monitored. This is the list of drugs, antihypertensives, which are being used: labetalol, nicardipine, clofazimine, and monitoring frequency I have told you. And there is also a red flag that if we are not able to reduce the blood pressure less than 185 by 110, do not administer alteplase. It is a relative contraindication, but if you are not able to reduce it, you cannot give. Antiplatelet therapy, I told you, patients should undergo a CT if they have been thrombolized at 24 hours, if they have undergone thrombolytic therapy or thrombectomy, so that antiplatelets can be initiated after 24 hours. Within 24 hours, it is not much of benefit, but it may harm. But within 24 hours, it can be initiated if there is a need, if there is an indication, because there could be certain conditions like deep vein thrombosis, or if there is peripheral embolization like limb ischemia. In those cases, we may need to start anticoagulation or antithrombotics before 24 hours. Anticoagulation, similarly, as per the indication, for example, if we have cardioembolic stroke, again, it has to be initiated after 24 hours if the patient has undergone thrombolysis or thrombectomy. There are other interventions in acute stroke, which are volume expansion, vasodilatation, hemodynamic. These are all symptomatic immediate management, which should be done as per your findings. Neuroprotective agents, still there is no evidence, so we do not recommend. There is emergency carotid endarterectomy or stenting is again still debatable. If patient has undergone thrombectomy and is managed following that, then the carotid artery stenting or endarterectomy can be done within 7 days or 14 days for better secondary prevention. Another dreaded complication is if there are large infarction, then patient may require surgery or medical management, that is we call cerebral edema or brain swelling. So medical management will include osmotic therapy, and commonly we use is diuretic or osmotic therapy in form of mannitol and furosemide or other diuretics. We can maintain a brief hyperventilation so that we get PCO2 of 30 to 34. But hypothermia or barbiturates are not recommended, and corticosteroids are also not recommended. patients may require decompressive hemicarinectomy. So I would want to clarify with various trials, what are the cases who will undergo decompressive hemicarinectomy as per the trials. If patient's age is less than 60 years and he or she deteriorates within 48 hours from this cerebral edema, then they should undergo decompressive hemicarinectomy. Nothing. If there is malignant infarct less than 60 years, within 48 hours, they should undergo decompressive surgery. More than 60 years of age, within 48 hours, again, they should be considered for decompressive hemicarinectomy. But in cerebellar infarcts, they should undergo, if there is occlusion of the fourth ventricle, there is hydrocephalus, and there is deterioration in neurological status, they should undergo decompressive suboccipital cranectomy with dural expansion and ventriculostomy. So finally, I would be concluding with the indications of decompression is if you have age 18 to 60 years, severe NIHS, there is malignant infarct and within 48 hours. Seizures, we do not recommend prophylactic anti-seizure. Recurrent seizures, if you are seeing, then it should be treated. So finally, I would want to conclude with this slide. So I could cover this acute inpatient care, the acute ischemic stroke who are coming in our hospital emergency. So pre-hospital and emergency and acute inpatient care, I could summarize. However, there is prevention, stroke rehabilitation, community reintegration, and recovery after stroke care. They are also very important. Thank you. Hello.
Hello. Thank you very much, sir, for the descriptive presentation on the much needed and very important topic in like today's era. So thank you very much, sir. So there is one query that has been like posted on YouTube, sir, and I will read out for you, sir.
Okay.
Thank you, sir. What are the key points to manage a case of stroke at primary health facility at periphery?
Okay, so at periphery, I must congratulate that this is the question which we are also not worried, but we are concerned because if you see my checklist and management of stroke, what we need immediate is first is identification whether the patient has stroke or not.
Yes, sir.
So first you identify clinically whether the patient has stroke and do a blood sugar, check vitals, clinical examination, but very quick, because if you have a CT machine, CT facility, then at least do a CT and you can give patient benefit of thrombolytic therapy. And if there is no CT facility, so better if you can shift the patient to a stroke ready facilities as early as possible, because without a imaging, we cannot start any specific therapy because it can be harmful. So at peripheral level, I must say that please identify if it is a stroke. And if it is a stroke, then do a blood sugar basic evaluation and do a CT and give at least benefit of thrombolytic therapy if it is ischemic stroke.
Right, sir. So there are no further queries, sir. It was explained well in your presentation. So I think with this we can invite Professor Ajay Kumar Sood, sir, for the vote of thanks.
Thank you so much, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, we are really grateful to the esteemed speaker for this evening, Dr. A.K. Pandit, sir, for being with us and covering this complex issue of stroke in a very simple and comprehensive way. And I'm sure that our participants, they have really learned from it. Thank you so much for giving the practical tips. And we look forward for your support in future also as a NAMS faculty mentor. Thank you, sir. We also like to place on record the support which we have been getting from Dr. Padma Shri Vasta madam. She has been the chief coordinator for this series on neurology, and she has identified the speaker as well as the topic. So we are really grateful to her for her support to National Academy. I would also like to thank all the participants who have attended this session. for being with us and asking the question, which has made this session more interesting. Another information for the participant is that the next session in the series is due on 27th of July, where again we are going to have a very interesting topic of multiple sclerosis. So please do join, and in case you have any question, please send to us. We will request the speaker to cover those areas in their presentation. In the participant, I also noted one of our council member, Dr. A.K. Sharma sir. So thank you, sir, for joining, and your presence has been always encouraging to all of us. So we are really grateful to you. I will also like to thank Dr. Preeti and Dr. Jaswant, who have been helping us right from the beginning when we started this Navigate Medico CME program in the planning as well as organizing this session. So we are really grateful to you for your support to the National Academy. The NAM's IT office, which includes Mr. Ravi and Mr. Anil, they have helped us in organizing the transmission of this particular session on Zoom as well as on the YouTube, and also they have been helping us in the background writing to the participant and the experts. So thank you so much for your support. In the end, once again, I would like to thank all of you for being with us this evening. Thank you so much. Over to you, Dr. Jason.
Okay. Thank you, sir. Thank you very much, sir. So with your permission, we conclude this session. Thank you, sir.
Thank you.
Thank you, sir.